Welcome to Lighting Your Way, a podcast featuring exciting, hilarious, heartbreaking, terrifying, and joyful stories of real nurse advocates helping real patients get the best health care. Hi, I'm Nurse Betty Long. Each week, I and one of my nurse colleagues at Guardian Nurses will take you behind the curtain to help you better navigate the healthcare system when you or a loved one is sick or injured. Thanks to several listeners who sent in suggestions on what they'd like to hear on this podcast. Today, we talk with three of our Guardian Nurses team, Elizabeth Carpenter, Peggy Pierce, and Rebecca Zarkowski, who, among all three, have 45 years of emergency room experience. While they don't have just one story to share, we are calling this podcast Emergency Room 101, a primer for patients and families. We invite you to sit back, listen, and hopefully learn something you didn't already know about going to the emergency room. Welcome to the Lighting Your Way podcast, Liz, Peggy, and Rebecca. Thank you for making time to join me today. Liz, you have 4 years of experience in the ER. Rebecca, you have 10, and our Peg Pierce, with 30 years of experience, you must have been born in the ER. So I have a lot of questions for you, so let's get started. Okay, so let's start with you, Liz. You have 4 years in the ER, and I think most recently you were in the emergency room during the COVID pandemic, right? I think there's a lot of questions that we could ask. Let's start off with, if you could answer, what's the difference between calling 911, right, and driving yourself to the emergency room? Could you speak to that?
Yes. Oftentimes we see, patients and or family members drive patients in that could have maybe benefited from calling 911. I know most people don't want to call 911, don't think they're sick enough to call 911. But once you do elicit emergency services from EMS, there's many benefits. The EMS staff are able to, complete an assessment, provide oxygen, do EKGs that actually can be sent to the ER en route, where a physician can look at it even before seeing the patient. Oftentimes people are having heart attacks or strokes, and they drive themselves in, and time is very precious. And if they had called 911, some of that care could have been started en route.
Right, and when folks are calling 911, I think this is a common misconception, is that when they call 911, this is not just a ride to the hospital that they want to go to, right? That it's a ride to the nearest emergency room, correct?
It is, and EMS can show up at your doorstep. You can have a conversation with them, and you can refuse to get into the ambulance. But it is nice to be able to call and have that option and have some trained eyes assess you and help you make that choice.
Do you when you get to the ER, is there any difference in how you are received?
Yes. So ambulances call ahead. It's answered by a nurse and or staff in the ER that then obtain a bay or a bed, and a nurse and a doctor, and everyone's alerted, usually of what's coming in, how far out it is, and everyone can just prepare for that patient. That patient does not go out in a waiting area. They come right back to the bay. They get triaged and their workup begins by the staff.
Right, so it sounds like it's more advantageous to call 911 if you were having an emergent situation that is life-threatening.
It is, because when you walk in or pull up or show up, no one's aware of what's going on, and they still need to get that story. They still need to look at you, see you, hear you, to decide where to put you in the emergency room. Because there's different areas, usually in larger ERs, there's different areas that treat different conditions.
And I think that is what's typically called triage. I know that we've talked about triage in the warm-up. but there are, as you said, there's different zones, there's different pods, there's different areas. Can you explain for our listeners what it means, when they walk into the emergency room, what that process is going to look like?
Yes. So there's different ways of being triaged in the ER. There's your, standard, you drive in, valet your car, walk to the front window where a trained nurse or technologist takes your information, your history, usually gets a copy of your insurance card, and they're either going to decide to bring you right back to the triage area, a workup area in the front that wouldn't be, the bed and or stretcher that you're going to end up in, or they'll determine that you can safely wait in the waiting area where, you're put into a priority type of standing. There's times when triage is so overwhelmed and or the ER is open enough that patients will be escorted directly back to a bay where oftentimes the nurse that will have that patient can triage them. So there can be a triage team out front, but you can also get taken straight back, and triaged by any nurse. Most ER nurses have the skill of triage. And then obviously ambulances are straight back to the bays, and that's the third type of triage.
Right. Okay. So that explains triage. Rebecca, I'm going to shift over to you now. Liz has talked a little bit about the triage, about waiting, right? And there's different areas, whether it's a pod, and different ERs have different ways that they do triage. But can you talk a little bit about what the folks can expect on wait time? Because I know that's even on Route 76, there's billboards that say the ER wait time is 6 minutes and 7 minutes, as though it could be free if you got in under 10. But talk a little bit about what patients can expect during that wait time when they come in and present to the ER first.
So that can be the most frustrating thing for not just the patients and their loved ones, but also for the staff. So when somebody comes through triage, like Liz was referring, we do assess for how quickly you need immediate hands on deck. So you can be pulled right from triage back to a room, but more times than not, patients are stable and we can begin the workup out in the triage area, and it becomes a conception, I guess, from a patient perspective. When you're looking, you come in, you sit down, you've been waiting an hour and a half, and somebody who came in 45 minutes ago is escorted to the back. Right. So like Liz was saying, you've got to consider there's different levels of care that's being provided. There's a fast track in, out, like lacerations, breaks, casting, x-rays. You don't know what somebody else is there with. Right. So you have to appreciate that just because they're going back first does not mean that anybody's forgotten you. It means that there's a level of care available for that patient that's appropriate. The other piece is, in most triage settings across the country, we start a workup out in the triage area. So if you come in with a complaint, there are protocols so that care isn't delayed and it isn't unsafe. That does not mean that you're going to get back faster, but it also means that we're looking for the differential or the diagnosis or what the problem is, even while you're waiting in the waiting room. So a good piece of recommendation would be, after blood has been drawn, EKG done, vital signs done, after you've been out there for an hour and a half, it's okay to go up and ask if any results have come back. It's okay. I encourage it. Go up and ask them to recheck your vital signs, because you don't want anyone to forget about you. And it can feel like they are when you're in the waiting room.
Yes, that's one thing that I think piece of feedback that we get all the time is that patients feel like, they see other people going in and they're still waiting.
Yeah.
Right. So I think that's important. If it's less urgent, there might be a bed available more quickly than there would be for something more serious. So it's kind of a oxymoron. Right?
Correct.
Yeah.
Correct.
Peg, thank you, Rebecca. Peg, I want to shoot a question over to you. So who can I expect? So I'm in triage, I've been seen, and then I get back to a room. Who can I expect to be seen by when I'm being evaluated? Is it an ER physician? Is it a nurse practitioner? Who are the personnel in the ER?
Yeah, good question, Betty. I've worked in 3 different ERs, and I can tell you it varies from ER to ER. But most likely when you're just brand new, put in that bed, the first person that's going to see you most likely is going to be your nurse. Now, some places could have it that the med tech comes in and gets you into a gown and maybe, gets you kind of settled for the nurse. But usually it's the RN that comes in to see you first. And after that, it's going to be either the ER physician or some sort of mid-level provider. It could be a nurse practitioner. It could be a physician's assistant, or you might get a resident, and also it could be the doctor. Most places, they send a mid-level or a resident in first and gets the workup started, does your assessment, and then reports to the doctor, and then the doctor comes in. But it really all depends. If you're in an academic setting, that's most likely how it's going to go. If you're out in the community and, someplace that's far away from an academic setting, it may be the doctor that comes in to see you next.
And when that doctor comes in, is there anything in particular that I should ask as a patient? Like, should I ask, hi, doctor, who are you? And what's the game plan? Or what am I here for? Like, should I do anything as the patient? Should I?
Sure. It really all depends. A lot of places, when you come in with a certain symptom, there is, a thing that they can get started where they get certain bloods or an x-ray and get that stuff started. So when the doctor comes in and explains, oh, this is what we have, this is what we see so far. A good question to ask the doctor would be, is there anything else that needs to be tested? Did we cover everything? What's the game plan? Am I going to be admitted? Do I need medications? Pretty much the whole umbrella of what's going to happen to me while I'm here.
Yeah, well, one of the things that we see all the time at Guardian Nurses is that communication is an issue, no matter whether it's in the emergency room or on the floor or in your doctor's office, right? So that's what I wanted to encourage people to be proactive and make the ER staff communicate. As Rebecca said, if they're feeling like somebody forgot about you, to go back to the triage nurse and ask. And there's also if there is a need to maybe escalate, or if you're feeling a little like you've lost your nurse or maybe you've lost your doctor and you're feeling like nobody's paying attention, who, Peg, could a patient or a family, if family is with them, who could they ask for?
Sure. Ideally, the first person that you would be able to take your concern to would be your primary nurse. But if he or she is not available because you've lost them, the next person that I would ask for would be the charge nurse. Everybody has them. Every shift, every unit has somebody who's in charge of the unit that day. And if the charge nurse is not available, then you can go right to the nursing supervisor or the nurse manager. Nurse managers leave at a certain time. So if it's during the day, up till about 4 or 5 p.m., the nurse manager would be a good one to call. But if not, the next step would be the nursing supervisor, who runs the whole house. And depending on how big the hospital is, there's one or more. But that would be the next step to take it if you can't get anybody who is based in the ER.
Okay, great. Thanks, Peg. Liz, I want to shift over to you. We've talked a lot. I mentioned a little bit about COVID in the beginning, but certainly COVID has impacted all of our healthcare operations this year, and certainly has affected the impact of families being able to interact with their loved ones to the point of, really, I've heard many stories of families just driving up to the emergency room and dropping off their loved one and waiting in the parking lot. So in your recent experience, how has COVID affected emergency room visits?
COVID affected it greatly. Basically anyone that wasn't being treated was not allowed in. So it was the patient and staff. Which at times can make it very difficult. If patients were very sick, we were spending a lot of time on the phone eliciting, and this was more last spring during the hot time of COVID. For me, I got pulled back to the emergency room, and, we had to be on phones and iPads, and, it was difficult for everyone. It was difficult for the patient in the bed. It was difficult for staff, just getting information, getting history. Sometimes people are disoriented or they're so sick they can't share their history or they're confused. We also had a lot of nursing home population that ended up coming into our emergency room, that needed to be intubated, that, couldn't make decisions on their own, and we'd have to call family to get the okay to intubate. It was unreal and scary and awful for everyone. But, the teams all pulled together, and I wasn't working in the ER at the time, but, volunteered to go back down to help other ER nurses that I had been with. And it was, we all pulled together, they all pulled together, but it was like nothing we've experienced.
Right. Oh, I've that's the least that you could say, right? Nothing you've experienced. It was certainly a compelling year for nursing and for healthcare. So, do you see it more recently opening up? Have the ERs have Rebecca, Peggy, Liz have the ERs begun to open up? Are there visitors allowed now?
I feel that it's ER to ER and healthcare system to healthcare system that it's either let end, or if a patient is hospice or near death. I think pregnancy, although they get shipped right up to labor and delivery. It seems my most recent experience was that family was not allowed back, and I had to go through talking to the attending to get a family member to be able to sit with someone in a crisis situation.
Wow.
Because I do not want that crisis individual making decisions on his own.
Right.
Bring up a safety concern in order to get his dad to just be able to sit with him. So I don't think they're open. I think it's as needed per patient, per story.
Per patient. Right. So to Peg's point, so if I presented to the emergency room and had a dependent or someone who I needed to be with, can that be communicated to the triage nurse?
It can be, although I think family members are overwhelmed and often, don't want to anger or, make them mad. So I think they retreat and sometimes go and, like you said, sit in the parking lot. But I think if you have an individual or family member that cannot make decisions or interact with the doctor or nurse, or it's just, it wouldn't even be smart for the staff not to bring that family member back.
Yeah, and it feels like at a minimum, we should be able to do that, right?
I think at this stage, yes.
Yes.
Yeah.
Peg, Rebecca, do you want to add anything to that?
Yeah, I can add to that. So I think I agree with Liz that in general, it's slow going and it can vary from facility to facility. But I can say on a personal level, I have a special needs son who did need to go to the ER for something minor, but still needed to go to the ER. And they did let somebody come back with him because it just really wouldn't have been successful if they didn't. But I think it's it's case by case, and really, depending on what the patient needs, they'll let the person come back if it's really needed.
Okay. Yeah, I would hope that we're recording this in June, and June 2021, and it feels like the world should be opening up a bit, and that we should be able to get back to, I don't want to say normal, but people come to the ER with their loved one, right, who wait with them in the pod, in the room, in the bay, and that should be kind of the normal. All right, Rebecca, I'm going to switch over to you. Now, this is a hot topic because the opioid epidemic still rages in our country. And I know that a lot of adjustments have been made to physicians prescribing medications, particularly from the ER or post-surgery. But really, talk a little bit about how the expectations of getting pain meds has changed in the ER. How have doctors kind of adjusted?
Yeah, this has been difficult for a number of years and continues to be. Everybody has to do their part, including healthcare, who probably was the largest contributor to the problem initially. So it used to be, ER physicians and PAs and NPs would write for a liberal amount of pain medication to get you through with consideration to how long it would be before you could follow up, if they had to give any pain meds at all. And that definitely has changed. Traditionally now, narcotic pain medication is necessary, they will give you just enough to get you to the point 3 to 5 days to follow up with a provider that can actually continue and follow care and do the full workup to see how to manage the care. So what does that mean for the patients? You know, a lot of times it's very frustrating. If you're making a trip to the ER, you're paying the copay, you're in pain, and then to hear, we're going to send you home, take Tylenol, take Motrin, and you're thinking, I could have just done that and did not need to come in here and give you, you know, however many hundreds of dollars for a copay. Understanding that this epidemic, nobody wants to bear the responsibility for losing someone or someone becoming an addict or codependent. And so because of that, there had to be some control, especially in the emergency department, where it's very difficult to track patients from one ER to the next ER.
Okay.
Oftentimes, you know, we have said over the years there should be some kind of a universal messaging system so that you can prevent over prescribing medication without even knowing you're doing it. And it continues to be something that is an issue in ER and throughout healthcare altogether. So what I think the lesson for anyone listening is, you don't go in there looking for just the medication to band-aid the issue. You're going there to get worked up to make sure there's nothing life-threatening. And if you can deem that you're safe to leave, as awful as it is, you need to trust that they're doing it for your best interest, not to be mean or difficult.
Right. That's a good distinction, right?
Mm-hmm.
It's a life-threatening. We want to make sure you're stable, right? It's not the ER. What's the saying that the ER nurses say? It's we're not. maybe none of you want to admit that in public. Okay, never mind. Forget that question. Peg, let me. Rebecca mentioned something about leaving, right? So let's talk about leaving the emergency room against medical advice, which is often referred to as leaving AMA. Some people don't want to wait, right? Some people are tired and they just go home. We had a patient last week who didn't want to wait in one ER, and the next day she presented to another. So talk about against medical advice. You know, how is that documented? How is it explained? Like, obviously there's risks, right? So what are the risks? There's a lot of questions I have, but talk to me about when patients sign out AMA.
Sure. I've had many patients sign out AMA over the 3 decades I worked in the ER. You know, and sometimes it's unfortunate because you really want them to stay and you're genuinely concerned about them, and you plead with them, please just consider staying. But when they do decide they do want to leave against medical advice, it's when the doctor wants to keep you, you know, for whatever it is. They want to keep you overnight, or they want to keep you longer in the ER, and they want to keep, you know, working you up or getting you admitted, and the patient just says, no, I'm out of here, I'm leaving. There is a form, it's the AMA form, the Against Medical Advice form, and the doctor will fill out the risks that are involved with leaving, you know, and sometimes or most times I would say death is one of them, you know, that, you know, once you leave here, you know, we're not at.
That's significant.
Yes, you know, it really, and all the other risks that could happen. And, you know, once pretty much the paper says that once you sign this paper and you leave this ER, we're not at fault if any of these things should happen to you. And it's most often presented to the patient by the nurse, by the ER nurse, and then the nurse will witness the signature, and, you know, unfortunately, then they'll leave after they sign that form.
So they have to sign the form. If they don't sign a form, and, like, you know, you said you've had a lot of patients leave, like, what if you go back to the room and they're not there?
Oh, that happens a lot too. That's when the patient gets what they want out of that stay, but you're not done with them, and it's called elopement. And you just go back to the room and you find them missing. They're not there, and the gown is
Not the romantic elopement, I'm assuming.
I'm sorry?
Not the romantic elopement.
Not even close. Yeah. You find the remnants of their patient and they're not there, and you just put that in your charting, you know, the patient eloped.
Okay. And then I know that there's been some discussion about whether insurance, I know that when patients wanted to sign out AMA on the floor, it was always, well, we don't know if the insurance company, they reserve the right to not pay. That was always kind of the caveat that we gave patients when they had been admitted and they wanted to sign out. So do you guys ever talk about that to patients?
Yeah, and I've heard it a lot, if you leave, your insurance might not cover this ER stay, and that's not true. They're going to cover it as an ER visit. And it's usually, I think either it's used that maybe the person saying that doesn't know, or maybe they really just want to try to, have that patient think about things a little bit.
Well, it's the big bad insurance company, so nobody wants to get a $15,000 bill. So if that's the compelling reason that you stay, then so be it. Right? So Rebecca, we have a couple more questions, but I wanted to talk to you about one of the things that I think patients and listeners need to understand is that when you go to the ER and you present, and Liz talked about triage and Peg talked about you're going into a department in the hospital. And that hospital has critical care units, it has operating rooms, it has a lot of other patients that are being cared for. And therefore, the lab, the radiology, all the supporting units that are supporting the patients that are inpatient are actively working to support those inpatients. And therefore, the emergency room often is at the, I don't want to say beck and call, but at the,
mercy of available.
At the mercy of available equipment, right? So patients need to know that it's not that you're neglecting them or that, you're waiting for their lab results, you're waiting for the x-ray, or you're waiting for the CAT scan, for the cameras being used for someone else. Can you talk a little bit about the flow and even in terms of bed availability upstairs?
I was going to speak to that. So, excuse me. The ER is absolutely dependent, it has no control, right? You don't have control when people are going to be discharged on the floors. You don't have control of when an ambulance is going to come through the door, and you have no control over who's coming through the front door and what level of acuity there are, right? You could get how many gunshot wounds in a night, right? You have absolutely, and drop at your front door. Right. So fortunately for the patients, ER nurses and doctors and other staff is very well managed to handle that kind of chaos. It's like organized chaos.
Okay. I've heard that before.
A little bit, right? So one of the things that I used to do with my patients is just communicate with them, right? If you let them know why there's a delay or why things are slow. Hey, look, there's no beds in the hospital. We're going to hold you tonight. I'm going to get you a bed. You won't sleep on the stretcher. We'll try and be quiet, but you'll be safe. Okay. Always go back to why they're there. They're not there for a hotel stay. They're there for a need, right? A medical need. Communication is going to be your best friend. The more you let the patient and their family know what's going on, and honesty, will they be happy about it? No, but can they fault you if they know why? Hopefully not.
Well, don't be so sure. Don't be so sure. Okay, so ladies, I have two more questions before we close, and I appreciate all of your insight into this, but here's the question. I'm going to go around. Liz, I'm going to start with you. What kind of things should a patient bring to the emergency room, right? I'm packing up, I need to go. This is not maybe it is 911, maybe it's not, but I'm coming and I have to go to the ER. What's the first thing I should grab?
Either your medication list, or if you don't have one, throw them in a bag, and it can be any bag, and bring them with you, because then you will get prescribed and given, your correct medication.
Okay, great. Peg, how about you?
I would have you bring on a piece of paper or on a card, hopefully it's in your wallet at all times, your medical history and the name of your doctors that take care of you.
Very good. And that, just a little plug for our listeners to make sure that you do put your doctor's names and your medical history on a little either 3x5 card, depending on how extensive your medical history is. But just keep that handy just so that you can, as Peg said, convey to the next practitioner. All right, Rebecca, no pressure. What's the first thing you're going to grab, or you suggest people grab?
So the first thing I would grab is my charger and a block.
Oh.
because
Okay. Is that a phone charger?
a phone charger,
Phone
yes,
charger.
and the block for the wall, because what you really need to bring is patience.
and that's spelled PATIENCE.
Correct.
Patience. Okay.
Right.
Got
So
it.
I think if you walk in knowing full well you're lucky if you get out in less than 8 hours, then you have nothing to be really, to your expectations aren't realistic. So bring your charger because you'll need it, and understand that everybody's working as fast as they can. I mean, everybody wants to be as safe as they can, and they're hustling and doing the best they can. So you just have to be patient.
Yeah. In all the times I visited an ER, both as a professional and as a patient, I've never seen people sitting around doing nothing.
Right. Exactly.
So it's
Eating
not like
bonbons.
they're eating bonbons. Okay. All right. The next question for all of you. And Liz, you're up again. So here's the $64,000 question. What one piece of advice would you suggest to patients that are listening, as it relates to an emergency room?
Piece of advice that I can recommend. Your average wait time is 6 hours, and if you get out before, congratulations.
Okay. Thank you.
Yeah.
Thank you, Liz. That's right. It's like, reminds me of the Southwest Airlines when they remind you that they have they've arrived early, and then everybody claps.
Yes.
So I guess if you get in more than in closer than 6 hours, you should be, playing the lottery next.
Not wait time, but processing time from triage to diagnosis.
Great. Okay. Perfect. Peg, how about you? What one piece of advice would you suggest?
I would say get to know the ER around you, right? The ERs around you. If you live in a community that's far out there and you have one ER, that's where you're going to go. If you live in an urban setting and you have many, many academic universities near you, pretty much you're going to get the same care no matter where you go. But if you kind of live like in the middle of those two types of settings, in a suburban setting, you might have more than one community hospital to choose from. And I would say get to know which one, because not all of them have the money or the resources to be, to have every kind of service, imaginable. One might have a cath lab. The one next door might not. One might be, certified stroke center, and the other one might not. Sometimes these community hospitals are kind of in cahoots, like, hey, listen, you do the cath lab and we'll do the stroke center. So I think it's a good idea to know what you have around you and who specializes in what.
That's a great suggestion. So Rebecca, you're our last contestant here. So what one piece of advice would you like to give our listeners as it relates to the emergency room?
To communicate, to share, be honest with your nurse and your physician. They're not judging you. They've seen everything, and they can help you best if you're completely honest with them about your symptoms, recalling the events, and speaking candidly about your lifestyle if it's impacting your healthcare.
Wow. Well, that's a great suggestion to end on. Liz, Peg, Rebecca, thank you all for giving us your expertise. I hope that I never see an ER in my lifetime. But thank you again, and take care. Thanks for joining.
Thank you.
Thank you.
If you have any questions that you would like us to address in a future episode, please email us at podcast@guardiannurses.com. That email again is podcast@guardiannurses.com. We would love to hear from you. Thank you for joining us this week. You can find the Lighting Your Way podcast on Apple Podcasts, Google, YouTube, Spotify, and Stitcher. If you liked what you heard, tell a friend and leave us a review. You can learn all about Guardian Nurses Healthcare Advocates on our website, guardiannurses.com. So until next time, find some joy in your life, pet all the good doggies and kitties, and remember to tell your people that you love them. Take care.